surgery. That's massive. After Caesars, moms were 50 times more likely to die after the procedure than women living in higher income countries. Another study looked at global variations in post-operative mortality and complications after cancer surgery. And again, the absence of consistently available post-operative care facilities was associated with the 7 to 10 more deaths per 100 major complications in LMICs. And the cancer stage alone, so the time of presentation, didn't explain enough of that in that huge variety in post-operative complications. Back to ASOS, a major issue there was the failure to rescue. 95% of the deaths occurred in the post-operative period, and it seemed that failed surveillance of deteriorating physiology was a massive issue. Not only that, but acting on that deteriorating physiology was part of the big reasons for all these deaths. So they went to ASOS 2 and they trialed 5 interventions to see would these interventions have effects on those numbers. And they were things like admitting the patient to a higher care ward, increasing the frequency of post-operative nursing observations, assigning the patient to a bed in view of the nursing station, allowing family members to stay in the ward, and placing a post-operative surveillance guide in a visible position at the bedside. So what did they find? Well, it was difficult. It was difficult to recruit enough countries and patients. And where they did, the outcomes weren't convincing. The implementation of it was actually just really hard. Only 40% were able to include the bedside surveillance guides plus 1 additional component. Under 60% were able to implement 2 or more, and less than a fifth of hospitals delivered on all 5 of those interventions. Was that a failure? Well, it still made 3 major contributions. It showed that in Africa, in a low resource setting, studies led by Africans like this was feasible, but woefully underfinanced. The fact that these trials were happening, well, they're really useful, but they stress a already stressed system. So it stressed the local healthcare system and the providers to make time to fit in and to do this work on top of the normal clinical work. And as we saw earlier, there's a real challenge of implementation of these strategies. So that creates a bit of a background. And we realize that there are some major issues in terms of need. Access is a huge concern, but it can't just be about access. As we roll out surgery, as we jump from a cesarean section rate of 3.5 to close to 15, which would probably include all the patients that need Caesars, yes, there will be more complications. But I think we need to also bear in mind that with those complications and mortalities, your overall numbers should be getting better. And part of that is picking up these patients that are post-operatively running into trouble, and perioperative care becomes an incredibly important part of that, not just what's happening in the theatre. So Ravi, I'm going to hand over to you. Thank you, everybody.
Thanks very much, Simon, and thanks, Caroline, and thank you all for being here on this beautiful Friday afternoon before a long weekend. And so I'm going to talk you through an area that I'm quite passionate about, and we'll go through this. It's probably going to be more like 25 minutes, but this will be enough time for discussion at the end. Can you all hear me? Caroline, can you just give me a thumbs up?
Yes,
okay, great.
the slides are here. Right.
Okay, great. So I'll get straight into it. I don't have any conflicts of interest. And briefly, what I'm going to do is provide a background on perioperative care, look at the Enhanced Recovery Program, share some of our local experience, and discuss our views on scale-up. So just to ensure that we're all on the same page, when we talk about perioperative care, what we're referring to is a patient-centered, multidisciplinary, integrated approach to delivering the best possible healthcare throughout the perioperative journey, from the time of considering surgery until full recovery. And if you had to just pause there for a second and think about our clinical experience, you would see that and realize that we very seldom, if ever, meet these goals. And when we talk about patient-centered and real evidence-based medicine, this is what we're looking at. We're looking at ethical care for the individual patient. Yes, there's evidence, but it must be individualized and it must allow for expert judgment. There should be shared decision-making and a strong clinician-patient relationship. We've got to bring the humanity of care into what we do. And to take this any change to scale, we've got to have an evidence-based public health platform. So if you look at some of the limitations on the day-to-day level of perioperative care, LMICs and South Africa, is that we realize that it's seldom patient-centered. It's even more uncommon for it to be evidence-based. In fact, it's estimated that less than 15%, yes, you heard right, 1.5% of what we do is evidence-based. That's today. That, as you would see, is that we tend to continue working in silos. There's even teams that do believe they have MDTs. Very seldom is there true working as a team. We focus very little on pre-op optimization. We have very little data. The little that we do have is often in the form of paper. And if without data, you cannot effect change, you cannot measure processes, and you cannot make improvements. So in response to this need, the Enhanced Recovery After Surgery program evolved. And in essence, it's an innovative service delivery platform that is patient-centered, data-driven, evidence-based, and adopts a multidisciplinary approach to perioperative care. It was conceptualized in the mid-90s with a collaboration between Denmark and Sweden and the UK. And as you can see, it is predominantly from the global north. But it subsequently evolved into an ERA society in 2010. And one of the big attractions to this society is that it's across all disciplines. It involves everyone involved in perioperative care. And over the last 7 years, we've really developed a true, well-functioning North-South collaboration. And in a nutshell, it is a paradigm shift in perioperative care, and they've gone and reimagined how to address the gaps in conventional perioperative care. And in essence, there's three pillars. There's the evidence-based guidelines, an implementation program, and you've just heard how difficult it is to effect change without this. But equally important to an implementation program is a monitoring and evaluation tool. So the society has made this evidence available via the society and is available for every surgical discipline just about. The implementation program really focuses on building well-functioning teams, and they have a database with almost 300 data fields that are captured for every patient, and it's available real-time 24/7 for the entire team. So let's look at some of this. The guidelines itself is divided into fields that are pre-op, intra-op, and post-op. And you would see, if you look at this, that a lot of this is very elementary. It is kind of things we should be doing, but actually hasn't translated to a change in clinical practice. So let's look at some of this. We all see this in our wards. Patients are kept in open mouth for surgery the next day. But let's look at the background to this. And when we first started doing surgery, this was the guidelines: clear fluids up to 2 hours, no solids for up to 6 hours. This was Lister back in 1883. And then we had Mendelssohn's classic paper that changed the world in 1946. But let's look at this. He had just over 44,000 patients, 66 patients aspirated, and 2 patients died. So this spawned a whole lot of research to look at the merits of whether what was being done then was safe. But just to remember that at this time, anesthesia was largely nitrous oxide and ether with a face mask. There wasn't really any significant intensive care therapy. So one of the other key seminal papers that was presented after that was this, where people went to look at the gastric content to look and see whether we can guide clinicians on what will be the best period to fast patients. And this was the key drive eventually became, is that we got to ensure that there's not more than 25 mils of gastric content and the pH had to be 2.5 or less. This was thought to be the ideal way to prevent vomiting and aspiration. But if you look at the study, the sample was one patient, and that sample patient was a rhesus monkey. And what they had done was inject 25 mils of gastric fluid in the right main bronchus. But this single study changed the way we practice for the next couple of decades. And what do we know? That actually aspiration today is extremely uncommon, that gastric emptying of liquids is an exponential process, and the half time for water is 10 minutes. Clear fluids is emptied in 95% of patients within an hour. So the guidelines have changed to back what Lister was talking about in 1883. Clear fluids up to 2 hours and solids up to 6 hours. Good evidence to support it. If you look at our clinical practice, you would see it's invariably not followed. What about bowel prep? I'm a general surgeon. We used to use bowel prep for every patient having surgery to the colon or the rectum. But in 2007, 2 large multi-center trials showed it made no difference, absolutely no difference to patient outcomes. Has it changed practice? No, it hasn't. If we look at the study, we asked our colleagues at a conference 6 years later after that publication, what are they doing? 42% were still using bowel prep routinely. What about the nasogastric tube? We all see this, we see it used all the time. And is it really necessary after abdominal surgery? Well, let's look at it. First described in 1991. And it's used because we think it can help prevent ileus and nausea and vomiting. And we look at the nasogastric tube, even though we're using it for just over 100 years, we don't know what the indications are, how to insert it, when to confirm, and how to confirm its position. What is normal drainage? When is it safe to remove it? And there's still significant complications from inserting a nasogastric tube. Again, if you look at the evidence, it shows there's no benefit. And this has been around for more than 3 decades. In addition, the second trial showed there's an increased risk of atelectasis in patients with a nasogastric tube. And if you step back, the simple nasogastric tube is a huge business. In the US in 2015, they spent $440 million on nasogastric tubes. And it's estimated that in that year, its unnecessary use cost the industry $1 billion. But pharma has got to play a role as well. Pharma has to do all these kind of marketing analysis to be able to just position their product and decide how to market it. And if ever you want to see a good review on what the effect of pharma in the medical profession is, go and watch this with John Oliver. It's an incredibly refreshing look at the profession. What about feeding post-op? Traditionally we wait for the patient to pass some stools and flatus and wait for the nasogastric tube to decrease, wait for bowel sounds, and we're concerned that patients are going to vomit, they're going to aspirate, or we may disrupt our anastomoses. But actually, most patients today don't get an ileus, and most patients, the gut function can return in a very short period. But actually, what drives these ileus is actually poor perioperative care, and I'll come to some of that shortly. So after bowel surgery, the current evidence is patients can eat on day 1, and this is supported by good level 1 evidence. What about intravenous fluids? We prescribe this every day in our lives. We very seldom realize that it is a drug, and it is the commonest prescribed drug in clinical practice. After using this for more than a century, there is no ideal fluid. And if you look at normal saline, which we often ask to put up for patients, it's anything but normal saline. it has 22.5 grams of salt in a liter, which is 4 times the daily recommended allowance in 1 liter of normal saline. This is equivalent to the amount of salt in 60 packets of crisps. It's crazy. And when we look at fluids and intravenous fluids, there is an extremely narrow band of where too much or too little can cause damage. And what I'd like us to visualize whenever we put up a drip is the cell wall thickness. It is a fraction of a millimeter in size. And just remember the potential damage if we give a patient too much of fluid. And then pain management. If you look at our clinical practice, it's far too dependent on opioids. Opioids simply will result in a patient that's nauseous, sedated, unable to mobilize, unable to eat or drink. And there's been huge evolution in pain management. And the key drive at the moment is to use a multimodal approach, use a combination of anti-inflammatories together with local and regional blocks. And in that way, we can use an opioid-sparing analgesia. And I could go on with just about every other element of these guidelines and highlight the changes that's happened and the reluctance to change at the same time. But I'm going to move on from here and look at this from a slightly different angle. And for those who's got an interest in physiology, you would remember that after surgery, well, at the time of commencement of surgery, patients go into a huge catabolic state. And we also know this is far in excess of what a patient needs to heal. And it's characterized by a state of insulin resistance. And this catabolic response goes on for weeks and then followed gradually by a period of recovery. What we've come to realize is that a lot of what we accept as standard of care actually drives this catabolic process further downwards. And if we can optimize our patients both before surgery and during the time of surgery, we can get patients recovering quicker. What we also know with these guidelines is that if you employ them into patient care individually in isolated elements, you don't get the benefit. When it's implemented as a bundle, there's almost like a synergistic effect. And Simon has alluded to this, and this is one of the key aspects, is you got to have an implementation program, because these are fundamentally changing the way we've been taught and the way we've been trained. And so there's a dedicated implementation program using change management skills to build the teams and effect change. And this we run over a period of 8 to 10 weeks. But the key player in this is the ERAS nurse coordinator, who is really the glue that keeps the whole team together. So if you look at the outcomes, this is what the dashboard would typically look at. This is available to the team anytime, and we can see what our length of stay is, what complications, what procedures patients have had, and compliance. And compliance measures our adherence to process measures. And there's clearly a lot more detail behind each of these. So if you look at compliance, for example, the red implies non-compliance and the blue reflects compliance. So this is the kind of data where we can go back with the team, share the data, and drill down and see what are the barriers to improving compliance to these areas, and then effect change. And in essence, you cannot manage what you don't measure. So if we look at the global results for ERAS in colorectal surgery, the results are very much similar to most other specialties, is that significant reduction in length of stay, complication and cost. There's also a reduction in nursing workload, improved patient experience, and a return of investment of anything between 5 to 7 to 1 in the first year. We also see this is that as the compliance to the guidelines improves, complications decrease. This is an interesting study, and this was from a single center, which showed that if you can get your compliance above 70%, there's a 5-year cancer-specific mortality rate reduction, which which is quite remarkable. And it talks to the fact that we are able to reduce that inflammatory catabolic response in the perioperative period. So what about South Africa? We started discussions on this in 2010, and we established 2 centers, both in the Western Cape, and we implemented 4 projects. And I'll share the results of these with you briefly. The 4 projects, in total just over 1,000 patients. 3 of these projects were in the public sector and 1 in the private sector. One of the early projects was in the public sector trauma, looking at abdominal trauma, and we were able to achieve a significant reduction in length of stay. And this was one of the first studies in trauma worldwide. And clearly, given the trauma burden both in our country and in other LMICs, if we can duplicate this at scale, it can make a significant difference in improving access to care. In our urology, over 3 years, we've reduced mortality rate by 70%. And then at Colorectal, we also employed the program in the colorectal unit. And we looked at 50 patients before commencement, and then we've looked at our data, which this is about 6 months old, and our numbers are slightly higher. But our adherence to the guidelines was a mere 34%. And within 3 years, we've got this up to 68%, and we've already achieved a significant reduction in length of stay. The private sector data was across 3 hospitals in the private sector, 5 teams. We had 457 patients, and our median length of stay was 5 days. This is a significant reduction. Actually, it's more than 50% of the national average in South Africa, where it's at 11.5 days. And our compliance to the guidelines remained at an extremely high level within that period. These results were in keeping with international benchmarks. This is unpublished, but we looked at some cost study in this early on, and we've been able to achieve an overall cost saving of 20% in our first 100 patients. And the sicker patients, we were able to achieve a cost saving of 27%. We've also done some modeling based on this study, is that we project that if we can implement this in our hospitals, we could achieve a saving of approximately 1.5 billion rands annually. We could create about 20,000 bed days per year. So by improving the quality of care within our tertiary hospitals, we can improve access to care without the need for increased infrastructure. And it also talks to value-based care, where we're improving outcomes by decreasing the delivery of the cost. So if you look at the program, when compared to conventional care, it really ticks all the boxes. And to give you a more visual experience, in most hospitals after major surgery, you would see patients lying in bed, nasogastric tube, catheter, foot pumps, and nothing to eat or drink, and sometimes a bit of water. But this is the kind of results we can achieve with improving our perioperative care. This man, similar age, 72, hypertensive, ischemic heart disease, and he's heading home day 1 after an anterior resection and a left hemicolectomy. I'm going to skip on this, but this is a patient interview sharing his experience, but we're under pressure for time, so I'll skip on that. So what has been the learnings for us with these pilot projects? I think what we've come to realize is that this program is perfectly suitable for tertiary hospitals and the private sector, both in South Africa and LMICs. But we do understand that this is not a model that we can use for primary and secondary hospitals, and that we need to have a program that's tailored to the generalist working in a really severely constrained environment. And we've started work on this. But we're also looking at developing a model in which we can be able to scale up this entire program. So what do we need? There's lots we need. I think one of the key steps is to work on advocacy and fundraising, because there are costs involved. And within Colorectal, the Colorectal Trust has taken on the program, and trying to raise funds. So if anyone can contribute, that'll be great. But just on advocacy alone, if you look at this, and just this is remarkable stats, firstly, 6 times more people die today after surgery compared to HIV, AIDS, malaria, and TB combined. There is no international platform to raise funds for perioperative care. But the global fund for HIV, AIDS, TB, malaria is in excess of $4 billion annually. So we got some work to do. But we got some work to do in almost every aspect. We need to do to get patient advocates so that we can understand each other's needs, how to overcome language and cultural differences. Look at financial planning, return to work. How do we help a patient who's lost a limb, who's the breadwinner for his family, to go back to work? How do we support them during the time when there is no income? Palliative care, there's huge gaps. We're still having difficulty with policymakers and funders on how to engage. And the team needs to be much bigger. We need implementation scientists, public health specialists, OTs, psychologists. And we need to change our teaching and training, both for undergraduate and postgraduate level across the entire spectrum, because for somehow we expect this training to happen by simple diffusion, but it needs to be much more structured. And there's huge amount of space for locally relevant research. So I think if you have a passion for any of this in any field and you're interested, we need you. Drop me an email. It is time for change. And I'm going to conclude with this slide from 2 of our greatest leaders that we've seen in South Africa. So Gandhi said, "You may never know what results come from your actions, but if you do nothing, there will be no results." And Madiba, we can change the world and make it a better place, but it is in your hands to make a difference. Thank you very much. Sorry.
Yeah, thank you so much for an incredible talk, Dr. Ravi, Oodit, and also Simone. Just to highlight a couple of things that I listened to from Simone's talk, where he talked about their 5 interventions of SS2. It was quite alarming to know, like, out of the 3 major contributions that they saw, that actually the studies led by African surgeons were feasible. They do have potential, but they were woefully underfinanced. So the question is, what can be done to make sure that our African surgeon studies, they are also funded, because they could also make a difference. And we know in LMIC, that's where more problems are. And then also, I'd just like to say this program that you have presented about, Dr. Oodit, it's a very good program, looking back at how you introduced us to the conventional care limitations and how it kind of covered that, where you showed that it's quite important to not work in silos, but to work in teams. And also, again, how you mentioned that it's quite important that there is an improvement of ensuring that we don't have lack of quality data to effect change, which your program is covering that. But again, one question, when you said this mostly works for tertiary hospitals, how can it also be, expanded for others? And I liked one, because I'm more of a scientist, where you showed the physiological stress response, where you were showing about their post-operative complications, and how it is important that maybe optimizing our patients before surgery can help them recover quickly, which will also help with the downstream work. Yeah, so that was a very good work. And the last one, yes, we need to change. We need to work together, and definitely more funding should be given also to surgical care and surgical delivery. With that, I would like to open up the space for questions and answers, obviously from the speakers, and also any comments. We still have some time. Thank you to our speakers for keeping to the time. So any questions, you can just raise your hand, and then, yeah, or comments. Okay, there we go, Anissa. Okay, you can go ahead, Anissa.
Thank you. Thank you so much for an excellent talk and some insight. I wanted to know, have you had any success in engaging with nursing colleagues in an attempt to sort of deconstruct the siloed way in which we work to improve patient outcomes, because we know they're key, but I must admit, I've really struggled, and I continue to struggle to do so.
A great question, Anissa. Thank you very much. So it's one of the key things about an implementation program is that you can pull everybody together into the same room, and you share ideas, you share what you're trying to achieve, and you listen to what the barriers are and try to look at the enablers for that. On a bigger scale, it is about a mindset shift, because the South African, on the positive side, the South African Nursing College has now created a job description for a perioperative nurse. So that never existed until a few years ago. So that's been done. But what the training entails and the career path, that hasn't been established yet. And then if you look a bit more broadly in Zambia, in their INSOAPs, they have a perioperative nurse, and she, Lillian Nwapa, and she is just a brilliant champion in improving care. So identifying leaders, upskilling, and allowing them to champion this is crucial. And it's got to happen at two levels. It's got to happen from ground up, but it's also got to happen from top down as well.
Thank you. Another question, comment? There we go. You can go, Ndalu.
Sorry, I was muted.
Okay, okay.
Yeah. Thanks, Dr. Ravi. Very interesting insights, like my colleague mentioned. As I think for me, it's even strange to note that making patients starve for 6 hours began in 1886. I never even thought about that. Yeah. My question though is, you mentioned the issue of pain medication post-op. Right now in the United States, you have what you call an opioid crisis, where lots of patients are addicted to opioids, morphine, fentanyl, and the like. And currently, I'm based in a ward where we often have oncology patients, and part of our care is to make sure that they have got adequate analgesia, and part of that is basically morphine. And we've seen the complications of morphine, where you have an ileus, but if you give morphine, it can cause constipation. And after morphine, we switch them to tramadol, which is also an opioid, which can cause constipation. And so you have patients staying on the ward because you can't send them home because they haven't yet passed 2. And that's probably one of the post-op requirements that you want. So it's a bit of a dilemma. And how do you traverse through such challenging decisions on how to balance adequate analgesia, and also with what the insight that you've provided? Yeah.
Yeah, Ndalo, you've summarized the problem beautifully. And unfortunately, your problem is not unique to your institution. If you go to any hospital in Africa, or most LMICs, we still use predominantly a morphine-based post-op care. So a couple of things with it is that, yes, there is a place, but it should not be the only modality of treatment. So if you look at the simple paracetamol, which is available both intravenously and orally, fantastic analgesic. Anti-inflammatories, there's a whole host of them. And usually between that and anti-inflammatory, short-acting opioid, if you need to, you can control patients' pain. The key thing is to have an analgesic plan for the patient before they start the operation. Let's work hard for that patient. What exactly are we going to do? Because everything you use has got potential downsides, but it's got to be a multimodal. You can't go with one drug. And if I could see Africa change and move away from morphine as its sole drug for post-op pain, it'll be a huge achievement in our lifetime. I think it is. So that's the one thing. The second is, passing stool is not necessarily a reflection that the bowel is functioning. If the bowel is functioning, if a patient can eat and drink and tolerate that, it means the gut is functioning. So again, we are stuck with the old school of waiting for the patient to pass flatus, waiting for the patient to pass stools. So discharge criteria from now is the patient able to eat or drink? Can they mobilize? Is the pain well controlled? That's really what we should be aiming for. The next is this patient happy to go home? Is the family happy to have them home? And is the perioperative team comfortable that this patient is ready to go home? Those are your 5 discharge criteria. That's how much we've changed.
Great. Thank you for the answer. And there's Char, you can go ahead and ask.
You probably mute.
Yeah.
Great.
Yeah, good afternoon.
Afternoon.
And
Hi.
thank you to the 2 presenters for the presentation. You see that the main issue is early detection of complications, and factored into that is the quality of post-operative care, and which depends on the human resource for health. And then besides that, there is also the issue which you have raised, the job description for the post-operative care teamwork. And if they are not well defined, that has an impact on when things are detected or when trouble is detected. But then we have to have policy, and the policy has to be based on data which you are generating. And then you come to the aspect of limited human resource for health. And then if you do advocacy, we always, you can get a positive response, and then it is a factor of resources in hiring these human resources for health to take care of or to do early detection. So you find yourself, or we find ourselves in this loop, and then the challenge is, where should our priorities lie? Where should we put more effort? And how do we get out of this?
Okay.
Thanks very much, Ro. That's a great question. And yeah, there's many aspects to perioperative care, from the time we start planning surgery to the time the patient's recovered and discharged. And I don't think we can look at any one of those steps in isolation. And therefore, I think that having the global picture is crucial, and working towards that goal is equally important. And each one of us can contribute and plug in slightly differently. But I think before we do anything in trying to address the problems with the infrastructure, we've got to at least agree on what is the common goals in perioperative care and what we agree is the standard of care. Once we implement that, then the rest will follow. Then we can fine tune, because as you point out, it is fine to have a standardized guideline for post-op monitoring. But if the person monitoring the patient doesn't understand that a blood pressure of 60/20 is a problem and it's a crisis, or if there isn't a communication channel on how to escalate that care, or the surgeon's gone off and he's the primary caregiver and has gone off for the weekend, we got a problem. So you've got to be able to first standardize care. This is my feeling is, once we standardize care, we can then look at the microsystem factors that play within an institution and fine tune it.
Great. I see the small hands. I will give it to Tejere, and then after that, Susie, you can go ahead. Anissa, I just want to know, is your hand up again, or maybe there was a mistake, you forgot to put
New
it
hand.
Or it's a new hand. Okay, so because we have 4 minutes, I will give it first to Njere and Susie, and if we have time, definitely, then you will go ahead, then before I close. Yeah, okay,
No
great.
problem.
Let's go in that order. Tejere, you can go.
Thanks, Caroline. Dr. Ravi, nice talk. I think from my perspective, in my department, obstetrics and gynecology, we're really embracing the fact of, ERAS and, optimal perioperative care. And I think, some of the highlights from your talk is the institutions should own the care for the patients without having to look for additional costs. You're optimizing your care, you're enhancing the patients going home early. And so I think once the standardized protocols are in place and, collectively with the nursing system, the doctors, and just that, to have no gaps in communication, I think this is a very attainable goal and enhances patients' outcomes. So I think that's just my contribution. Thank you.
Thank
Thank
you.
you very much. Important points.
Great.
Yeah, just before we take the next speaker, if anyone wants to stay on and run a bit longer, I'm happy to stay for another 10, 15 minutes if need be.
Great. Susie, you can go ahead.
Hello, good morning. Thank you so much, Dr. Ravi, for that excellent presentation. I'm actually in Edmonton in Canada, so it's very interesting for me to hear your perspectives from South Africa. Furthermore, I'm still a medical student, so I'm hoping to start my residency in July. So it's also very interesting to hear about all of these historical reasons for some of our current practices. In terms of ERAS, I know our colorectal service here in Edmonton does use ERAS, but some of our other services don't. So that's also interesting to see that here in Canada, we still have, limitations in perioperative care. My question for you is, in my readings regarding global surgery, I've also seen the use of the WHO safe surgery checklists to help improve perioperative mortality and care. I'm wondering, what is the role of that in South Africa, and how does it differ from ERAS? If you can just clarify a little bit on that. Thank you so much.
Well, Susie, welcome, and thank you for joining us. It's a pleasure indeed. Well, if you want to know anything about ERAS, go to Alberta. They're doing phenomenal work in your country, and there's incredible teams there driving Alberta, and they've done some of the landmark research globally on ERAS. So, great question. So if you look at current evidence, there's only two things that's actually shown to make a difference to perioperative care. One is the surgical safety checklist, and the other is the ERAS program. There's level 1 evidence. But if you look at the surgical safety checklist, the uptake has been extremely poor in LMICs. But when it's used effectively, as in high-income countries, the results have been very good. So the question is, again, why is the implementation not that effective? And essentially, it is because we lack a proper implementation tool when we do it in this country, or in LMICs in general. So we are currently working on a project where we are combining the surgical safety checklist and the ERAS program into one checklist. But the key difference between the WHO guidelines is that it is more global, it's a more system-related safety checklist, and doesn't do sufficient to be patient-specific. So we are trying to marry those two to try and come up with one tool that we can all use. And I do think that the teams who have used so when we do the ERAS implementation, one of the key things we do bring into the workshops is the surgical safety checklist.
Great. I'm gonna just close, but then definitely we'll have Anissa's question so that everybody who wants to go, they can go. Firstly, I would love to thank our speakers. What great session we did have, and it was quite interesting to hear more insight on the challenges of perioperative care and in low middle income countries, and also some different perspectives from all the participants. And yeah, looking forward to the next academic meeting in the next month. But I will say those who wants to stay on, just for us to give Anissa a chance to ask a question, because Dr. Ravi is still available, it's okay. And those who wants to rush somewhere, it's okay, you can also leave. But thank you so much for joining us for today's session. Great. And Anissa, you can go ahead and bye to those who leave, but it would be nice if you stay on just to hear. It might be a good point what she's going to be asking. Thank you.
And I've actually put it in the chat. It was more of a comment with regards to the post-operative pain management,
Okay.
because I also have a meeting at 2 o'clock. But I feel very strongly that, you know, there's a narrative around this opioid pandemic that's in the global north that doesn't really apply when we're talking about Africa. Africa only orders and uses a fraction of the global opiates, what is happening globally in terms of consumption. So we can't deny that we can't go opioid free, we can go opiate sparing for sure, but it is a crucial element, but we're neglecting the other elements. So just to complement what Dr. Ravi said, ketamine is available almost ubiquitously. It's a safe drug and it's an incredibly effective analgesic. And it's something that we're not utilizing to its full potential in the post-operative or perioperative setting. Where it can be given orally, it can be given in low-dose IV infusions, and it really is a fantastic adjunct. And when it's used in those doses, you manage to avoid all those unwanted side effects. The other thing that we don't focus on a lot is the non-pharmacological pain management stuff that we use quite effectively in our children. And if you can teach a child to do deep breathing techniques for relaxation and pain management, then you can definitely teach an adult to do that. So our physios are fantastic at doing that. So I think that we need to find more contextually applicable non-pharmacological pain management strategies in our environments and utilize those effectively.
Great. Thank you. I think that's about it. Thank you, everyone, and enjoy your afternoon. Bye, and thanks to the speakers. Bye.
Thanks very much, everybody.
Goodbye. Thank you very much, everyone.
Thank you.
Bye, everyone.